Sodium loss also causes secondary loss of potassium. So this is particularly hazardous if the patient is given digitalis. So you have to give also with caution your diuretic kasi your diuretic will cause also sodium loss. So di ba, exchange ito hira. So sodium loss, may kaliwat potassium loss. So it may cause digitalis toxicity or potentiate the development of your digitalis toxicity if you are giving digitalis. Hypokalemia can be treated with potassium supplementation or through addition of an ACE inhibitor or a potassium-sparing diuretic such as your spironolactone. So your spironolactone or eplerenone is considered in all patients who have moderate or severe heart failure. So your ACE inhibitor is used first in patients with left ventricular dysfunction but no edema. But studies have shown that ACE inhibitors are superior to both placebo and to vasodilators. So it's also a first-line therapy for chronic heart failure, aside from your diuretic. ACE inhibitors, however, cannot replace digoxin in patients already receiving the drug because patients withdrawn from cardiac glycoside may deteriorate while on ACE inhibitor therapy. So your ACE inhibitor, as I've said earlier, is both a preloader and an afterloader. So it's a balanced dilator. The ACE inhibitors will slow the progress of ventricular dilatation so that it will also slow down the downward spiral of the heart failure. So ACE inhibitors are beneficial in all subsets of patients. Your AT2 angiotensin T1 or angiotensin AT1 receptor blockers like your losartan, they have beneficial hemodynamic effects similar to your ACE inhibitors. In clinical trials, it suggests that your ARBs should be used only in patients who cannot tolerate your ACE inhibitors because of cough. Vasodilators are divided into your selective arteriolar dilators and venous dilators, and drugs with non-selective vasodilating effects. So the choice of agent should be based on the patient's signs and symptoms and hemodynamic measurements. So patients with high feeding pressure in whom the principal symptom is dyspnea, they would benefit with your venous dilators, so your long-acting nitrates. So they will reduce your feeling pressure and the symptoms of pulmonary congestion. Now, in patients in whom fatigue due to low left ventricular output is the primary symptom, then they will benefit more with your arteriolar dilator, so like your hydralazine. So it will increase the forward cardiac output. In severe chronic failure that responds poorly to other therapy, so you need to check the feeling pressures. So there could be an elevated feeling pressures and reduced, thereby you have a reduced cardiac output. So you have to dilate both the arterioles and the veins. So balanced dilator. So in a clinical trial among African American patients receiving ACE inhibitors, the addition of hydralazine and isosorbide mononitrate reduced mortality. So fixed combination of these two agents has been made available as isosorbide dinitrate hydralazine or your BDIL. And this is approved for use only in African Americans. So, but this is not available in the Philippines. So your beta blockers and calcium channel blockers. You have trials of your beta blocker therapy in heart failure, and they are based on the hypothesis that excessive tachycardia and adverse effects of high catecholamine levels on the heart contribute to the downward course of heart failure patients. So it's beneficial if initiated cautiously at low doses. And improvement is noted when there is already a slight rise in the ejection fraction, as well as slowing down of your heart rate and reduction in symptoms of heart failure. So not all beta blockers have proved useful for heart failure. So these three drugs, your bisoprolol, carvedilol, and metoprolol, have been shown to reduce mortality. Now, calcium channel blockers have no role in the treatment of patients with heart failure. They are depressants, so they have depressant effects on the heart and may even worsen your heart failure. So digoxin is indicated in patients with heart failure and atrial fibrillation. So it's most helpful in patients who already have dilated heart and third heart sound. So it's given only when diuretics and ACE inhibitors have failed to control the symptoms. So only 50% of patients with normal sinus rhythm will have relief of heart failure from digitalis. So the better results are usually obtained in patients with atrial fibrillation. So your digitalis is not commonly used in patients who are in sinus rhythm with heart failure, but rather beneficial effects are observed for those patients with heart failure with atrial fibrillation. Mulat benefit. So when symptoms are mild or slow loading with your 0.125 to 0.25 milligrams per day is safer and just as effective as rapid method of 0.5 to 0.75 milligrams every 8 hours for 3 doses. So that's the dose of your digoxin. So you need to measure the plasma digoxin levels, especially for those who appear unusually resistant or sensitive. So levels of 1 nanogram per ml or less is appropriate. So moderate but persistent, it has a moderate but persistent positive inotropic effect. So digitalis, in theory, will reverse the signs and symptoms of heart failure, but it has no effect on mortality. It may reduce hospitalization and deaths from progressive heart failure at the expense of an increase in sudden death. So the mortality is reduced in patients with serum digoxin concentrations of less than 0.9 nanograms per ml and increased in those with digoxin levels greater than 1.5 nanograms per ml. So the other clinical uses of digitalis includes management of atrial arrhythmias because of its cardioselective and parasympathomimetic effects. Also, the depressant effect of the drug on atrioventricular conduction will help control an excessively high ventricular rate of your atrial fibrillation and atrial flutter. It is also used in the control of paroxysmal atrial and atrioventricular nodal tachycardia. So digoxin is contraindicated in patients with WPW syndrome or Wolff-Parkinson-White syndrome and atrial fibrillation. So toxicities of your digoxin include visual changes and GI disturbances. So it generally requires no more than reducing dose of the drug. Now, if cardiac arrhythmia is present, a more vigorous therapy may be necessary. So serum digitalis and potassium levels and ECG should always be monitored during therapy of a significant digitalis toxicity. So electrolyte status should be corrected if this is abnormal. Now, in cases of severe digitalis intoxication, serum potassium is elevated at the time of diagnosis because potassium loss from the intracellular compartment of skeletal muscles and other tissues are usually observed with severe digitalis intoxications. So usually the automaticity is depressed. So your antiarrhythmic agents administered in this setting may lead to cardiac arrest. So they are best treated with prompt insertion of a temporary cardiac pacemaker catheter, and administration of your digitalis antibodies or your digoxin immune fab. So the antibodies will recognize the digitoxin and cardiac glycosides from many other plants. So they are useful in reversing severe intoxication with most of your glycosides. So for digitalis-induced arrhythmias, they are frequently made worse by cardioversion. So this therapy should be reversed or reserved for ventricular fibrillation if the arrhythmia is glycoside-induced. So cardiac synchronization, resynchronization therapy. These patients with normal sinus rhythm, but they have wide QRS interval. So if the QRS interval in your ECG is greater than 120 milliseconds, they will have an impairment in the synchronization of your ventricular contraction. So if you have poor synchronization of left ventricular contraction, this will result in a diminished cardiac output kasi they synchronized. So resynchronization is indicated here with left ventricular or biventricular pacing. So it has been shown to reduce mortality in patients with chronic heart failure who were already receiving optimal medical therapy. So for diastolic heart failure, so most of the clinical trials have been carried out in patients with systolic dysfunction. So the evidence regarding the superiority or inferiority of drugs in heart failure with preserved ejection fraction is meager. So what is important here is to control hypertension, and then revascularization should be considered if there is coronary artery disease. Then tachycardia also limits the filling time. So bradycardic drugs may be particularly useful in this case. So for acute heart failure, this usually occurs in patients who already have chronic failure. So the episodes are associated with increased exertion, emotion, salt in the diet, or non-compliance with medical therapy, or increased metabolic demand associated with fever or anemia or even infection. So common and important cause of acute heart failure with or without chronic failure is acute myocardial infarction, as I mentioned earlier. So that in this case, emergency revascularization using either coronary angioplasty and a stent or a thrombolytic agent is recommended. Even with revascularization, acute heart failure also may develop. So may myocardial stanning. So measurements of arterial pressure, the cardiac output, the stroke work index, as well as the PC wedge pressure are particularly useful in patients with acute myocardial infarction and acute heart failure. So you can give intravenous treatment here. May give diuretic. This is the most commonly used. And then may use also dopamine or dobutamine because these drugs has positive inotropic effects. This will prompt the onset and shorten the duration of action. It has a prompt onset as well as a short duration of action and is useful also in patients who are severely hypotensive, especially dopamine. Your levosimendan has been approved also for use in acute heart failure in Europe. And non-inferiority has been demonstrated against dobutamine. So vasodilators also can be given in acute decompensation. And this includes your nitroprusside, nitroglycerin, and deseretide. So they will reduce the afterload and improve the ejection fraction. So a small subset of patients with acute heart failure will have hyponatremia due to increased vasopressin activity. So your V1 and V2 receptor antagonists, which is your conivaptan, is approved for parenteral treatment of euvolemic hyponatremia. So there are already clinical trials, and it has indicated that this drug and related V2 antagonist may have beneficial effect in patients with acute heart failure and hyponatremia. So I already have mentioned the different drugs for heart failure. So I guess that's my last slide. Thank you for listening. Are you all awake or asleep?
Awake pa daw.
Awake pa. Sige, nag-attendance ka na?
Yes, Doc. Done na po.
Okay, sige. Saan ba that next meeting? Next week, Wednesday.